chronically the way we expect them to. And one of the most important reasons why this occurs is because the disease is not classified correctly, and as a result of which the patients get undertreated very frequently. So let us look at how to classify this disease, first based on the periodicity. So disease is considered intermittent if there is an inflammation-free period of at least 2 to 3 months after stopping the medications. And if this phenomenon does not occur, then the disease is considered chronic. So basically, within a month of stopping the medications, the patient comes back to you with a recurrent disease. Now, when a patient comes at the first visit, how do we establish if the disease is intermittent or chronic? This we can do based on the past history. How frequently does the patient use steroids? What has been the response? And what has been the period of remission? Very frequently, we will also see this kind of a clinical picture when the patient presents to us, and this should not be mistaken for active allergy and should not be mislabeled as chronic allergy. These patients will have this kind of, especially in this part of the population, will have this kind of pigment dispersion over the conjunctival surface, and it is important again to go back to the symptomatology of the patient to understand whether the patient does have a chronic disease or not. So now that we have understood how to classify based on the periodicity, let us look at the severity. So there are several classification systems that have been explained in literature, based on which the disease can be classified into these 4 categories. It is considered to be mild if the patient predominantly has symptoms with a few papillae. Moderate disease is when the patient has up to 6 clock hours of limbal involvement. And when this becomes circumferential, when the patient has macroerosions, or if the patient has giant papillary conjunctivitis, then the disease is again termed severe. And blinding is when the patient develops sequelae because of allergic eye disease, either in the form of limbal stem cell deficiency or shield ulcers. So let us look at, since we are discussing chronic allergy, let us look at the management of mild, moderate, chronic allergy first. When a patient has an acute episode, the first modality of treatment is topical steroids. We can either give surface-acting steroids such as loteprednol, etabolate, or severe potent steroids in severe disease such as prednisolone acetate. Now, because this is again a disease that is limited to the ocular surface, it is very important as far as possible to limit ourselves to the use of surface-acting steroids such as loteprednol, which has an efficacy very similar to that of prednisolone, but because of the esterases that are present in the cornea, it gets deactivated and does not penetrate into the intraocular structures. So the rate of ocular hypertension that can be attributed to loteprednol is the least of all the steroids. So the patients are typically given a short tapering course of these steroids over 4 to 6 weeks, and this is combined with either antihistamines or mast cell stabilizers. Now, within these group of medications, there are several molecules available out there. So the first 2 are the mast cell stabilizers, levocabastin is an antihistamine, and the last 4 are dual-acting agents. So when it comes to mast cell stabilizers, they have a very slow onset of action. They typically require 4 to 6 weeks for the effect to set in, but when they do set in, they have a prolonged duration. Antihistamines have a very short duration. They do not last more than 4 to 6 hours, but they are very rapid onset. However, in isolation, they are very rare. It is very rare to use antihistamines alone. And the last group of medications, the dual therapy, combines both the effect of the faster onset of the antihistamine with the prolonged action of the mast cell stabilizers. Now, because these patients have a chronic disease, it is also important. So these are the different studies that have looked at the effect of all these different molecules, and they have not found any difference in the effect of any of these medications when it comes to antihistamines and mast cell stabilizers. So the use is a personal preference. So now, because these patients have a chronic disease, they have to be placed on a maintenance therapy, and the most common group of medications that is used over here are the topical calcineurin inhibitors, and this includes topical cyclosporin and tacrolimus. And there is a lot of evidence in literature that supports the efficacy of these medications. And when it comes to a head-on comparison between these 2 drugs, they have similar outcomes, similar rates of steroid independence that can be achieved with these 2 topical medications. However, because tacrolimus is a ointment, it has a once nighttime dose, and so it is easier to use in children since the majority of the patient population that is affected belongs to this category. So this is a patient who has around 6 clockers of severe limbal vernal keratoconjunctivitis, and the patient was again started on a short topical course of topical steroids along with mast cell stabilizers and tacrolimus. And with this therapy, the patient did very well and had a good resolution, and the patient was continued on this dual therapy of tacrolimus and mast cell stabilizers. And let me take you back to the pathogenesis slide to help you understand why this dual therapy is important. So as we can see here, we have one half which is attributed to IgE mediated or mast cell stabilizer mediated, mast cell mediated inflammation, and this is where the mast cell stabilizers will act. Whereas the other half of the pathogenesis is attributed to T cell mediated inflammation, and this is where the calcineurin inhibitors will act. And therefore, it is important that a combination of these two medications is prescribed when you see a patient who has a chronic disease to keep them on a good maintenance therapy. So also, patient counseling is an extremely integral part in the management of ocular allergy. It is important both the parents and the children are explained about the chronic course of the disease, the relapsing and remitting course, and the parents should be explained that every time the child has an acute episode, they should not prescribe or they should not get over-the-counter topical steroids. Self-medication with them and the harmful effects of these have to be clearly explained. And the fact that the child will probably require therapy for the next couple of years, maybe another decade, so that the patient doesn't go to a new doctor every time the child has a new episode. Another important point that has to be emphasized is the avoidance of eye rubbing and its role in the pathogenesis, because if the child continues to rub their eye, there is no amount of medical therapy that you can give that can help control the disease. So let us now look at the severe or the blinding form of vernal keratoconjunctivitis. This is basically when the patient develops sequelae. In papillary variant, these are the shield ulcers, whereas in the limbal variant, it is limbal stem cell deficiency. Shield ulcers, the patient will typically have very large papillae which are abrading against the cornea, causing epitheliopathy, which ultimately results in the ulcer. And the ulcer can be of three variants here. We can have a clear or one with a translucent base or one with an opaque base. So here the treatment is directed both at the ulcer and at the management of the giant papillae. First, let us look at the management of the ulcer. Ulcers such as this, which have either a clear or a translucent base, can be managed with topical therapy, very similar to that of the moderate to severe variant of allergy. And they do very well, so you can see this patient has completely responded just with topical therapy alone. However, when a patient comes with this kind of an opaque plaque, it is important to subject them to a debridement with or without an amniotic membrane graft. For the management of the papillae, what is traditionally described in literature is the use of supratarsal steroids. These are the steroids that are commonly used and they are given at the superior border of the tarsus. However, it is very important to understand that as long as the steroids are there within the tarsus, that is when the effect will be seen. And typically these patients will have a recurrence within 4 to 6 months, and so it is very important to follow up these patients accordingly. And in patients who have repeated episodes, they have multiple recurrences, instead of giving them repeated doses of supratarsal steroids, it is better to place these patients on systemic immunosuppression. And this is a very important arm in the management of patients with severe ocular allergy. As cornea specialists, we should not refrain from starting these medications for these patients. The two most commonly used medications in our practice is oral steroids and oral cyclosporin. So this was a patient who had this kind of a picture for almost 6 years before presenting to us, and the patient was started on oral cyclosporin and oral steroids, and we can see the kind of dramatic resolution that is seen in these patients with these medications. This has also been described in literature where even very severe shield ulcers have completely responded with oral cyclosporin therapy. Other modalities, surgical modalities that can be used for the management of these giant papillae include excision and covering the bare area with either a conjunctival or a mucous membrane graft. Again, this was one of our patients who had giant papillary conjunctivitis and had repeated episodes of corneal erosions. And so the patient was subjected to a shave excision, and the bare area was covered by conjunctival autograft, and the patient did not have a recurrence of the papillary conjunctivitis with this modality. The use of mucous membrane in a very similar manner has also been described in literature. So the other end of the spectrum, where the patients have a limbal variant of vernal keratoconjunctivitis, in the severe form of the disease, they can have limbal stem cell deficiency. So if the patient has a central clear area of the cornea, the patient can be managed with Crow's lenses and immunomodulatory therapy. Whereas the patient has this kind of a picture, then they are treated with limbal stem cell transplantation. So again, this was a patient who had severe limbal vernal keratoconjunctivitis. This is the response that the patient had with just oral steroids. However, when the oral steroids were tapered, as the dose kept decreasing, the patient came back with a recurrence. So since the patient was not able to, since we were not able to wean the patient off of oral steroids, we started the patient on oral cyclosporin, and we can see how beautifully the panels has regressed with oral cyclosporin therapy. So this is the image at the last visit. Now this is an image of a patient of total limbal stem cell deficiency following chronic ocular allergy. The image on the left, like I said, if there is a central clear area of the cornea, this patient can be managed with Crow's lens, and the patient did very well. And the right eye, the patient was subjected to an allo slit, and this is how the cornea magically clears with the surgical intervention. So some special considerations, the last segment of my talk. If keratoconus or corneal ectasia is again very commonly seen in these patients with vernal keratoconjunctivitis, and it is attributed to the eye rubbing because of the allergy. And they typically present with the advanced form of the disease. And when we are considering intervention for these patients in form of cross-linking, it is important to consider the age, the presenting pachymetry, and the severity of the allergy. The younger the child, the lower the pachymetry, the lower is our threshold to take these patients up for a cross-linking procedure. Also, it is important to stabilize the ocular surface before obtaining the scans, otherwise we may not be able to truly establish whether the patient is having a progression or not. Cataract and glaucoma, there are again two very commonly existing comorbidities in these patients, and the modality of choice for the treatment of glaucoma in these patients is aqueous suppressants. And pseudoepitheliomatous hyperplasia, again, not very rare presentation of patients who have moderate to severe limbal vernal keratoconjunctivitis. And this very commonly gets mistaken for ocular surface neoplasia because they have a very similar type of presentation, location of presentation. And the way to differentiate these two is based on an anterior segment OCT. So here we can see that the lesion, this is a scan of a pseudoepitheliomatous hyperplasia. We can see that the lesion is predominantly subepithelial. A clear intact layer of epithelium is seen above the lesion. This is the same image which is enhanced. We can see the line of the epithelium beneath which the lesion is there. And to contrast, this is a picture of a patient with OSSN. So here we can see that they have the clear sign of a demarcating line between the conjunctival and the corneal epithelium in the lower line scan, and that this lesion in the OSSN is actually epithelial with significant back shadowing. So pseudoepitheliomatous hyperplasia is either treated with oral steroids. Here we can see the patient has a wonderful response to the oral steroid